Good afternoon, colleagues. Good afternoon, all. Thank you so much for joining us on this afternoon. And welcome to the third installment of our monthly TB Think Tank webinar series. It is exactly 12 o'clock on the dot. And I see we have about 10 people with us. The numbers are increasing, which is good. Thank you. And with that said, I will hand over to before I do that, I'd like to just remind you, colleagues, that if you have any topics that you'd like to be presented on this platform in the upcoming months, please email myself on ngosi@tbthinktank.org. Please send your submissions to that email address if you'd like to be presenting on this platform in the upcoming months. And please do not forget to type in your questions in the Q&A box available up there at the top, and then your questions will be addressed at the end of the presentations. Thank you so much. I will hand over to my colleague, Jody, to introduce our speakers for today.
Sorry, Jody, you're on mute.
Thanks very much. Sorry about that. So I'm going to go ahead and introduce all of our speakers up front, and they'll just go ahead and give their presentations in succession. We also have Brian Allwood, who's joined us as a panelist. So I'll give everyone their introductions. Dr. Mohammed Siddiq Rasool qualified as a medical doctor from the Medical University of South Africa in 2003. He has more than 15 years experience in conducting clinical research in treatment and prevention of HIV and TB. He is currently one of the deputy directors of Clinical HIV Research Unit as part of the WITS Health Consortium and is responsible for the TB portfolio. He has a joint appointment with the University of WITS and is the current PI for the TB sequelae project. He currently serves as a member on the South African Department of Health National Third Line Antiretroviral Treatment Approval Committee and is a PI on multiple studies. Associate Professor Salome Charalambous is the Group Chief Scientific Officer at the Orem Institute. She holds a medical degree from the University of Wits and an MSc and PhD in epidemiology at the London School of Hygiene and Tropical Medicine. She has vast experience in medical research in the fields of HIV and TB. Brian Allwood is an associate professor in the Division of Pulmonology at the Stellenbosch University and Tygerberg Hospital. He initiated and heads both the multidisciplinary interstitial lung disease and pulmonary hypertension service at Tygerberg Hospital. He's a general pulmonologist, and his research interests include post-TB lung disease, and in particular, the pulmonary vascular effects after tuberculosis. He initiated and chaired both the first and second international post-TB in Stellenbosch, and he remains committed to teaching and training in pulmonology, and in particular, the training of pulmonologists for the African context. And finally, Denise Evans is a principal researcher at the Health Economics and Epidemiology Research Office, known as HERO, a division of the WITS Health Consortium, with more than 14 years of research experience focused on optimizing HIV, TB, and drug-resistant TB treatment outcomes. She has a joint position in the Faculty of Health Sciences at the University of Witwatersrand and as an associate professor. She is currently the technical lead of the TB research area at HERO and has worked on several health economic evaluations of TB, including a budget impact analysis on managing multi-drug resistant TB in South Africa. She is currently the lead of the socioeconomic research task for the TB Sequel 2 project. Thanks so much, and I'll hand over to Mohammed to take it away.
Thanks, everyone. Thanks for having us. It's a pleasure for us to be able to present our TB sequel project, and hopefully Salome and Denise will present some interesting outcomes from our project. So I'm going to be just giving an overview of what our project was. So TB sequel, it's a pathogenesis and risk factors of long-term pulmonary sequelae, defining the individual outcome and public health impact of TB and TB disease. Hopefully you can see my slides. So just some background of TB and its consequences. As we know, TB is still a global health emergency with little known about its long-term sequelae. There is some accumulating evidence that indicating permanent lung injury due to TB is frequent and substantial, and TB leads to the loss of longevity even in developed countries. There are limited number of studies evaluating the long-term pulmonary outcome of TB and the influence of risk factors on developing long-term pulmonary complications. In terms of the project and partners, it is funded by the German Federal Ministry of Education, and it's part of the Research Capacity Development Network. Our project, we have multiple partners, partners in Tanzania, Mozambique, South Africa, it's in Orem, partners in Gambia, then University of Munich, LMU, and the Borstel Center, Research Center in Borstel, as well as external cooperating partners with the WHO. In terms of our work package or the research itself, the aims of our research was to systematically assess and describe lung outcomes in African TB patients, to understand clinical, microbiological, host immune, genetic, behavioral, and environmental risk factors affecting the long-term sequelae of pulmonary TB, determine occurrence of reversible and irreversible costs and socioeconomic consequences of TB patients, as well as then design and facilitate novel host interventions to restore and preserve overall health and well-being in patients with TB. So our project had a research cohort which enrolled approximately 1,500 participants, and then from the cohort we had different research streams looking into the pathogens, looking into host immunology, looking at socioeconomic aspects, and then looking at therapeutic interventions in the study as well. And yeah, so the primary endpoint was looking at severe pulmonary function impairment measured by spirometry at 2 years from treatment initiation. And we had a whole host of secondary endpoints as well. So we were looking at any impairment of pulmonary function or abnormality measured by spirometry within the follow-up period, impairment of pulmonary function measured by the 6-minute walking test, and the use of the St. George's questionnaire in the follow-up period. We were looking at proportions of subjects with MTB culture conversions at 6 months and after standard treatment, proportions of subjects with TB culture conversion at specific months after initiating MDR TB treatment. Yeah, I didn't mention that our cohort had both drug sensitive and MDR TB patients in it, and had patients both HIV negative and positive as well. We're also looking at death related to TB disease or treatment during follow-up, and then obviously looking at the TB recurrence, specifically either treatment failure, relapse, or infection during the follow-up phase. Just in terms of the time frame, our protocol was designed at the end of 2016, and the project ran basically first enrollment was September 2017 until the end of December 2019. And then basically from beginning of 2020, 2021, we focused on follow-up and data cleaning and analysis. We had further work packages associated with our project as well, and that included capacity development. So in strengthening institutional capacity, we wanted to establish a cardiopulmonary unit at each study site. Not all sites managed to do this, but I think we did get to at least the initial stages of getting this implemented. And then as well as short-term training courses, as well as PhDs and masters that were done through this project. And then as well as networking, which was a specific work package to strengthen links between institutions via network activities. So it was basically strengthening links between our institutions within our project, as well as with other research networks as well. And then translation of evidence into policy, so there's networking between our local and governmental stakeholders. This is just a page on our social media and websites. And thank you to all the patients that took part in our cohort and all the staff, as well as our funders and the entire team as a whole. Yeah, and that's the overview of our project. I'm going to stop there. And then Salome can take over, share some results. Thank you. You're on mute, Salome.
Thank you for that. Thank you very much, Mohammed, for introducing the TB sequel cohort. I'm going to now try and share some of the results of the study. It's still, unfortunately, preliminary results. So just to, sort of take everything, we're still writing up and you will be seeing the papers as they come along. And mainly I'm going to be presenting the 6-month outcomes and the end of treatment outcomes, and then later outcomes where we have results. So as Mohammed has already said, there was a TB cohort that enrolled. We aim to enroll around 1,600 participants in the 4 different countries. And we followed these participants up. These were all TB, drug-sensitive TB patients, and they were followed up for quite a long time now. I'll be showing you a bit on that. And the part of the study was also measuring other factors such as host factors, pathogen factors, socioeconomic factors. Today, I'm going to mainly be showing you the clinical aspects. So that will be the follow-up of the cohort. And then Denise is going to talk to the socioeconomic costs and impacts. So this is just a sort of a timeline of the patients. We enrolled in total 1,430 patients and 284, sorry, that's an error. So I wanted to show how many were enrolled in South Africa. There were around 260 enrolled in South Africa. And you can see that so we saw patients at 2-month points while on treatment, and then after treatment at 9 months and 12 months. And we have now some patients up to 60 months and are aiming to follow them up to approximately 8 to 10 years. As Mohammed has already mentioned, the study started in around 2017. We completed enrollment in 2019 and followed everyone up over that period. And during this period, there was very little standardization of what exactly would need to be measured and followed up. And so, you know, so only in 2020 was the first international symposium on post-TB lung disease, as has already been mentioned. And at that symposium, some discussion started to take place about what would be the appropriate measures to take at different time points. So a lot of them, that also led to a document called the Clinical Standards for Assessment, Management and Rehabilitation of Post-TB Lung Disease, which was published in 2021. So in our cohort, really, it was a little bit, and this is kudos to the team at LMU. They spent a lot of time trying to understand what should be measured over this cohort over these time periods, and we did measure some of the aspects that were eventually part of the toolkit. We looked at functional capacity. We looked at the 6-minute walk test. That was the main test we used for functional capacity. For health-related quality of life, we used the St. George's questionnaire, and then we measured lung function using spirometry mainly, and we also did some radiology. So I will be sharing some of these results, as we go. So this just looks at the baseline characteristics of the participants on our TB sequel study. As you can see, the first numbers, those are the total enrolled. So 370 at the MRC in the Gambia, 416 at INS in Mozambique. And I think some of our colleagues from Gambia, Mozambique and Tanzania are also on the call today. And then from the MMRC site in Tanzania, we enrolled 284 participants. And from the VIT site in South Africa, we enrolled 359 participants. You can see that the majority of participants were male in all groups, which is quite in keeping with our TB adult population. You'll see there the mean age of participants, then the smoking history. That's just any smoking history, so not broken down by different types of smoking. And then past TB in 18% in South Africa, 11% overall. HIV status varied quite remarkably by the different sites. There was only 7% with HIV in the MRC in Gambia, whereas of our participants in South Africa, 69% had also HIV co-infection. And then the proportion that were then found to be positive who were on ART at the start, that was fairly low in our South African group. And then the CD4 counts were quite similar in all groups, in those who were HIV positive. And then looking at the BMI, some similarities there as well, with 19.4 as a median in South Africa and 19.2 overall. Some more baseline characteristics of the different sites. You'll see that the smear negativity was more common in the South Africa group and was 12% overall. And grade 3+ disease was quite common, especially in the Gambia and Tanzania, and only around 20% in the South Africa group. And then we also looked at radiology. We looked at different scoring systems that are being used. Those are just to determine extent of disease. And you can see the differences by site there. And then looking at lung functions. And so that was one of our main areas of interest. We were only really able to get spirometries done. It's quite complex and difficult. And also with patients at the beginning of TB treatment proved to be quite difficult. We were able to get lung functions done in 749 of all patients. And you can see how it's broken down. So the first column just shows for MRC Gambia, 70% had moderate to severe lung disease of those that were able to get lung functions done at baseline. And then in South Africa, 37% had moderate to severe lung disease, 31% had mild lung disease, and 31% had normal lung disease of those who we were able to do a baseline spirometry. So now, in the interest of time, I'm going to just go to some 6 months results to try and show you the results at the end of treatment. So the first is just looking at this is just on the lung function, a little bit more detail. I've already spoken about how many we were able to do them on, and how many then had a valid result. So we were able to look at 748, of which 619, so 82%, had an impaired lung function. And just to look at what type of impairment there was, so FVC below the lower limit of normal, so a restrictive lung disease in 70%, and FEV over FVC ratio below the lower limit of normal, obstructive lung disease in 6%, and then where there was a mixed impairment, it was in 19% of people at the beginning of treatment. So just looking at the quality of life and symptoms. So as I said, we use the St. George's questionnaire, which is a specific pulmonary type questionnaire for quality of life. And you can see that, and a positive score is the number of symptoms people are experiencing, or problems they're experiencing. And you'll see quite a high score at the beginning of treatment, which goes down quite rapidly after treatment at 6 months in all the sites. So the colors are the different sites. And in all the sites, you see the St. George's questionnaire total score reducing. And this at the end of treatment is the VIT site, and saying at the end of treatment, most people, they felt either good or very good. So when it comes to how people feel at the end of treatment, using the St. George's questionnaire, we were able to see that there was an improvement to the end of treatment, and in most patients said they were actually feeling good. But I will be showing you some of the other data that is not quite sort of indicating that health is quite as good by the end of treatment. So this is the 6-minute walk test, and the 6-minute walk test, the 6-minute walk test here is indicating that at the start of treatment. So what happens here is patients are asked to walk for 6 minutes, and we measure how far they've walked in meters. And you'll see at the start of treatment, this is the VIT site, people walked around 450 meters, were able to increase quite a lot. And these are just, there's quite a bit of variation towards the end, so don't worry too much about the post-treatment results here. But you can see that it does improve while a person's on treatment. And the figures to the right just indicate your males in red versus your females in purple, and just indicating the differences at the end of treatment by men versus female, having a mean number of meters of 517 in the first one, and 417 in males and 470 in females. Now, when we look at the 6-minute walk test, so what you do see that it does improve to over 30 meters on average, above 350 meters. So there's an improvement of more than 30 meters, and on average, everyone stays over 350 meters, which is a good sign. When we look at the 6-minute walking tests, though, by country, we see quite a bit of variation, and we do see that somehow the South African patients seem to be able to walk much further from the beginning of treatment and a little bit later. And we're not sure what actually affects this major difference. And there are no reference values available for African settings, so we think there might even be some cultural factors that may have played a role here. So the purple line, for those who can't see, that's the VIT RSA site, and the other lines are the 3 other African sites, with the red line being the Gambia site. Now, just quickly on spirometry, and sorry, I did already start talking about some spirometry measures, but just to remind everyone about spirometry. So this is a test where people blow into a tube, and we try to measure their lung volume through that. The first measure that we look at is the forced vital capacity, and that's the total lung volume that someone can put into their lungs. And that, we believe, is often affected by TB because it causes a restrictive lung disease, in that not enough air then is able to enter the lungs. And then the other big measure that is measured is the FEV, sorry, this the FEV1, which is about how easy it is for a lung to get out of the lungs. And that's really a measure of obstruction, and a lot of, so you measure what we call an FEV1 over FVC ratio to determine obstruction. So just a small recap on lung functions there, just to help us for the rest of the presentation. So one of the major things that we were interested in was measuring lung function. And here, you see the lung function scores for the total cohort, and you see it at the beginning of treatment, followed to the end of treatment. So from 0 months to 6 months in the project. And we look at 3 different measures. You'll see there the FVC, which is the yellow line, which is the first measure, which we said is the one that looks at mainly how much total volume of lung there is. And you can see that it is, so on the y-axis is the z-score, which is a comparison of these measures against the normal population of what we think is a standardized normal population. And you can see that the FVC at the beginning of treatment was on average less than 2 minus 2 z-scores below the average population. So very severely restrictive lung disease there. And then you can see that the FEV over FVC is not really so badly affected. So you can see that it's quite close to 0 or getting close to that. But the FVC and the FEV1, which are both measures of total volume, are severely reduced in the cohort in total. So this is the important part, is when it's below the 1.96 of the Z-score. But Prof. Elwood was telling me that that even if it's below 0, it means it's impaired. But we use this as being pathologically impaired. So in all the lung, sort of overall in the cohort, we had very severe impairment at the beginning of treatment, and then towards the end of treatment, still quite severely impaired lungs. Now, looking over the cohort over the longer period of time, you can see again the first 6 months in the first block, and then we followed patients up now over to 24 months, and you can see the FEV1 over FVC remaining quite constant, but the FVC being quite low at the beginning of treatment, and at the end of treatment still being very much low, still in the low and abnormal, pathologically abnormal stages, and then starting to improve again after treatment a little bit, but still staying below the abnormal level. And that was for both the FVC and the FEV1 in the majority of patients. So in total, around 4 to 7% improvement at the end of treatment compared to baseline, and a further 4 to 7% improvement up to 24 months, but still not reaching normal levels. Now we look at the same data, but now broken down by the different countries. And so now you can see there are quite a lot of differences. The purple line again being the South African group, and you see the other countries below it, and you see that at least even though all of these are abnormal because they're all below 0, we do get that in the South African group at the beginning of treatment, there's only a few that go into the really pathological group, and they do improve, as do all the others, by the 6-month point and then by the 24-month point. But they all remain below normal in the mild to moderate category of lung impairment. And you can see with the FEV1 even more that is severely affected. So what are the types of impairment that we see? So in the 852 patients with spirometry results at a 6-month point, we see that only 27% were normal. that the FVC was reduced in 48% of persons. There was airways disease in 6% of persons, and we think this airways disease might be also due to other pathology going on at the same time, could be smoking in these patients. And then there was a large proportion who had this mixed disease that had airways disease and a reduced forced vital capacity, so restrictive disease as well. And so a large proportion of patients have this mixed disease, 19% at the end of treatment. This is for the whole cohort. And if we look at the South Africa group, that would be it's slightly lower, but there is still a group that have this mixed airways disease at the end of treatment. So then looking at what happens to different airways diseases during time, and this was just looking at the different types of diseases and how they change over time. There's a tendency of more people to then end up at the end of treatment with more obstructive disease than at the beginning of treatment. And this is in keeping with other data from Malawi that also showed a change of pathology after treatment to increased obstructive airways disease at the end of treatment and 24 months after treatment. So we also looked for risk factors for these poor spirometry outcomes. And this is the initial results that we were getting, that there are a number of risk factors. One of them is BMI. So we found that those who are underweight had a 2.3 times higher chance of having a poor spirometric outcome at the end of treatment. And then similarly, also anemia affected the spirometry outcome. Having severe disease at the on X-ray at the beginning of treatment, having 3+ disease at the beginning of treatment, and being a smoker were all associated with having a poorer outcome, as well as past TB disease. Interestingly, factors that were not associated with poor outcome were sex, age, and HIV status, and culture status at the beginning of treatment. So why do we worry about spirometry? Well, there has been some studies that have been done that have shown that mortality and cardiovascular and respiratory morbidity is much higher in people who have an impaired FEV1. And that is what we were able to show in our study, is that people who have TB at the end of treatment and 24 months after treatment still have an impaired FEV1. And you can see here, this is this big trial that was done that followed patients up with having done spirometry and following up for cardiovascular and respiratory morbidity, was done in 17 countries. And you can see the high, those with low socioeconomic status, those patients in countries with low socioeconomic status had even more morbidity than those with middle or low socioeconomic status. So linking socioeconomic status of a country to morbidity and mortality from having a low FEV1. Some further data also has come out in a systematic review that showed that people who've had TB have higher all-cause mortality. And this also again indicating that this could be linked to having lung disease at the end of treatment. So just in summary, we did find that there was, in general, quality of life was reported as good in the great proportion of patients. However, even though there was improvement of all the tests, there was some problems with correlation between the results, and they do not always correlate completely with each other. And there was a high proportion of impairment, only 30% having a normal lung function and 20% having severe impairment at the end of TB treatment and 24 months after TB treatment. And risk factors were low BMI, extent disease on X-ray, past TB history, and smoking. Thank you. Just to again thank all the participants and the team. This was a photograph we took in Mozambique and around year 4 of the study, and just to thank everyone who was part of that. Thank you. I'll now hand over to Denise, who will take us through the socioeconomic work that's been done. Thanks.
Thanks, Salome. Thank you, and good afternoon, everyone. I'm just trying to see. Do you see my slides?
Yes, we do.
Okay, thanks. So thank you for that introduction. I'm now going to focus on the socioeconomic research task. And as Dr. Mohammed and Dr. Salome showed, the socioeconomic research task was one of the sub-studies of TB sequel. So before I start, I just really want to acknowledge the contributions from a large group of people and partners and research groups that have worked with us, as well as in the bottom line, we have a number of students, masters and PhD students that have been working on the TB sequel socioeconomic research task. So for the socioeconomic research task, we mainly have these 3 pillars, which really focuses on the cost, the consequences, and coping strategies as individuals and their families respond to TB. So for the cost part, we look at out-of-pocket expenses. We also look at lost income. And that is while individuals are seeking treatment, as well as during hospitalization. And we also look at the proportion of individuals and households that face catastrophic costs. For the consequences, we look at measures of quality of life, psychological distress, disability, disruptions in work, social and family life, as well as TB-related stigma. And then for coping, we look at ongoing school and work interruptions, how individuals and their households cope and what measures they adopt or what strategies they adopt to cope with the out-of-pocket expenses, as well as the lost income from TB. And this can be due to or result from borrowing money, taking out loans, or selling assets. And then we also look at the economic recovery as well as productivity, both during treatment and also after TB treatment completion. So just some of the key findings from the socioeconomic research task. So what we have found from the observational studies, and you can see this is an example here on the right-hand side, the top right, I include some of the data from the psychological distress. So here we used the K10 tool, and you can see at the start of TB treatment, outcomes or these measures are typically the lowest or the most severe. So you can see here 33% reported either they were likely or they were moderate or had a mental disorder at the start of TB treatment. We see the greatest improvement observed during TB treatment, so a decline here to 10% at treatment completion. And this trend is similar to what Salome described earlier. We see a limited recovery in this period after TB treatment completion. So a limited recovery then, and whether this is 6 months or 12 months after TB treatment completion, we see limited recovery. We have also observed that up to 20% of patients continue to report a poor quality of life, psychological distress, pain or disability at treatment completion. And some of the patients also continue to report prolonged poor quality of life. And this is different from the St. George's research questionnaire that Salome, the results that Salome showed you. Here we use the SF36, which more looks at general well-being and general quality of life. And so some individuals or some TB survivors still continue to report or perceive their quality of life to be low at treatment completion, and even 6 months after TB treatment completion. And you can see the figure on the right, they never perceive their quality of life to be equal to that of a comparator group that hasn't had TB, or even to healthy adults. We also observe, you can see the figure there on the top right, that at treatment completion and even 6 months after TB completion, that some individuals continue to report that TB has disrupted their work life, their social life, or their family life. We've also done some work around TB-related stigma. We have some results from baseline or the start of TB treatment, and contrary to what we thought, we could not show that HIV status contributed to TB-related stigma. What we did observe is that age, and those that adults that were older than 30 and even older adults older than 50 were more likely to perceive self-stigma as well as community-related stigma. So we are doing some work now about measuring, since we've been able to measure TB-related stigma at multiple time points, we are doing some work to look at the ongoing effects of stigma, as well as the impact of stigma on economic recovery following TB treatment completion. In terms of the economic impact, our work echoes that other work that has been published from other African countries. And the top right is data from Malawi, and we see a similar trend. If we looked at employment and the number of hours worked, typically these are the lowest at the start of TB treatment. We see an improvement on treatment, however, very limited recovery at the 6-month or the 12-month time point after treatment completion. You'll see at the bottom right, this is for data from South Africa, and you can see the orange, red and blue is for those that reported that TB had a moderate, serious or a very serious impact on their financial status. And so you can see at the start of TB treatment and at 2 months, about a third still reported this impact. And it improves on treatment. However, again, we see limited recovery after treatment completion. When we look at dis savings, so as I mentioned before, that's having to take out loans or sell property or borrow money, we can see that very few, less than 10%, need to do this after completing TB treatment. However, for those that have to adopt these strategies, the monetary amount is generally quite high. So what we have seen is that TB's economic impact really does continue well beyond TB treatment completion. So this is just some preliminary data. We still need to complete follow-up, and you can see the numbers have, we still need to add in the 12-month time point, but I just wanted to show how South Africa is faring compared to the other countries in TB sequel. And so as you can see, we've said, you know, as I showed the trend in the previous slide, we see an improvement in employment and number of hours worked from baseline to treatment completion, and then this very limited recovery thereafter. You can see very few people adopting these coping strategies, and it's good to see that that those individuals that have adopted these dis-saving strategies are able to start repaying loans. And then you can see a very small proportion continues to still report a serious or very serious impact on their financial status. And so if you compare that to the other countries, the response, you can see South Africa is doing better than Mozambique and Tanzania. I won't go through this in detail. I just really wanted to highlight that some of the other work that we've been doing is really looking at patient costs. So the out-of-pocket direct medical and non-medical expenses, as well as indirect, which is the income loss that patients experience. So we look at this before treatment and then also during treatment. And we also have been looking at the drivers and what are the main drivers for those out-of-pocket expenses. Also, some interesting work from the Gambia looks at some of the impact beyond just the individual, but looks also at the impacts of TB on the household. And this analysis in particular looked at the impact on child contacts and their school-going activities, their school attendance and school performance. And while we didn't see a change in school attendance, we did see a significant drop in school performance, and this is 6 months after 6 months interviewing individuals, but after they'd been on TB treatment for 6 months. So we saw that there was also significant drop in spending on school necessities like school fees, uniforms, shoes and transport. And we also saw that over time there was an increase in food security. So we do need to think about the long-term consequences for individuals in the household, particularly for children, if we look at this relationship between food security, school performance, and this may have lasting impacts for child contacts that can extend later into adulthood. We've also not only done the quantitative work, but have also done some qualitative work. And I'm not going to go into this in detail, but really just to highlight, and this is our interest around TB-related stigma, that stigma has serious consequences both during treatment and also after treatment completion. So particularly in women, we see ongoing work and school interruptions, and we are really interested in the impact on economic recovery. Just to highlight this block at the bottom, we've seen from the qualitative interviews that individuals or respondents really report a loss of their network support, which they depend on for job connections, and this has an impact then on the ability to seek employment and also impacts the economic recovery following TB treatment completion. Again, I'm not going to go into the details of this slide, but I just really wanted to highlight when we looked at the TB sequel participants, apart from education and setting, something that really stood out was those that reported that TB had a moderate or serious financial impact at treatment completion were less likely to stay in care. They were more likely to become lost to the study and not come for their post-TB follow-up visits. So the financial impact and really supporting TB survivors at treatment completion and following TB treatment is really important, particularly if we want individuals to come back for post-TB care. As part of the other pillars, where we are also interested in the cost, not only to patients and their households, we are also interested in the health system's cost. So we have also done some work around the cost for TB treatment. So this work we did in South Africa. We did a bottom-up micro-costing of drug-susceptible TB, both for inpatient and outpatient TB treatments. And so as part of that exercise, we also updated the national TB cost model with these costs and inputs, and that data has been shared with stakeholders, and we are repeating the same exercise in the Gambia and Tanzania. We have collected all the costs. We are just busy with the analysis of the health system's costs. And then just to mention that as we've gone along, we've participated in the post-TB symposium. We've also tried to pull together a lot of the data and the results that we have observed from TB sequel to look at how a lot of these measures and outcomes interact. We've looked at the long-term economic, psychological and social effects of TB, the ongoing side effects of TB treatment, as well as lung impairment, and then as I've mentioned, we've tried to look at the interaction between some of these measures like physical exercise capacity, economic position, stigma, pain, distress, and how that all impacts an individual's perception of their quality of life. And so we're also working now, some of this data has fed into the post-TB health and wellbeing clinical statement, as well as our recent participation in the post-TB symposium. So just to touch on TB sequel 2, which now is the follow-on from TB sequel 1, which started this year in 2023 and will carry on for another 5 years. We will really continue following TB survivors prospectively and looking at their long-term socioeconomic consequences, trying to identify which patients are most likely to benefit from interventions, as well as conduct economic evaluations to determine the cost and impact of interventions and strategies to improve post-TB lung health and reduce the long-term consequences of TB. As part of the socioeconomic sub-study, we have now a health economics modelling component that will really try to predict the impacts and benefits of these interventions on on individual health outcomes. And then just as an example, one of those activities as part of the socioeconomic research task, one of these activities is to really look at the individual preferences for a person-centered post-TB care. So we plan to do qualitative and quantitative interviews, which will inform the design of a discrete choice experiment. And this is just an example here on the right-hand side to show what these are like hypothetical scenarios. And then TB survivors can choose which type of post-TB care package, what they would like that to look like. And as I mentioned, these attributes and levels will be informed by the data that we get from quantitative and qualitative interviews. Yes, and then as everyone has mentioned, it's a really great network. So we're really grateful for all the partners and the patients and all the teams on the ground that have been involved in collecting data and making this work possible. So thank you very much. I'll end there now. Thank you.
Thank you very much to all of our speakers. Some really interesting data coming out of this study and a lot to come. I'm going to hand over to Luwazi for the time being. I think we've had one question come up so far, but we'd like to encourage you to ask questions in the chat. And Luwazi, do you want to cover that question? Perhaps Salome can answer it again.
Thank you so much, Jody. As Jody has mentioned, I think we would have time for just one more question as we have under 8 minutes. So the question in the chat is asking whether you included community controls for the spirometry and the 6MWT. And perhaps, Salome, in your response, could you just elaborate what the abbreviation stands for others who might have missed it or not aware of what it stands for?
Okay, thank
Thank you.
Thanks, Nawazi. It's the 6-minute walking test that's being referred to there. And for South Africa, we didn't do any studies on controls because we felt there was enough information available at the time. I mean, obviously, we're also limited by budgets and so on. But because there was really no information, we did try, in some of the other African countries, we did try to enroll controls, and we did enroll controls in Mozambique, actually, as another study that was done just before TB sequel started, and then in Tanzania as part of TB sequel. And so there is some data on controls. I don't think we have got to the point where we've actually used that to actually look at the results from those two countries to see if they need to be adjusted and how that needs to be done. So it was a good idea to collect the data, but I don't think we've actually used it yet to adjust the results based on that data yet.
Thank you so much, Salome, for that. Perhaps do we have any other comments from the TB sequel team that they'd like to explain before we close off this afternoon?
Maybe we could ask Brian, if you want to maybe make some comments based on what we all presented. Brian is a new member of TB Sequel and has joined TB Sequel too, but has also helped us, supported us in understanding our results and interpreting them. Thanks.
Yeah, I mean, I think these results is just to kind of annotate a couple of points. I think you have to highlight a few things. The one thing is that these patients are young. And, you know, even though those graphs looked like we drew the dotted lines, and as Salome pointed out, they were kind of centered around somewhere between -1 and -2 Z scores, but that is not normal. Normal is naught, and should be centered around naught, a Z score. And so these people are left with a respiratory impairment. The other thing that's very exciting about the TB Sequel data going forward is we're going to look at the trajectories of decline as well. Over the subsequent the TB Sequel 2 and what's going to happen into that time period, because you've had this drop in lung function which is associated with tuberculosis. The question is what happens next. We've seen that there is some improvement, you get back to your new normal, but then what happens after that? Do you have an accelerated decline? Do you have a consistent decline? We don't know, and that is a very exciting thing to do. But I think what is really important for this forum to appreciate is that TB doesn't end with microbiological cure. And I think, you know, people have done TB trials for the last however many years, but nobody's looked at lung outcomes. So we can't, for example, tell you what an MDR, how an MDR regime compares to a rifampicin INH-based regimen in terms of lung protection. You've got these treatment shortening regimens, and all of that kind of thing going on, which sound fantastic, and the cures of the microbiological cures seems to be equivalent in many of the regimens. But what about the lung outcomes? You know, at the end of the day, people want to be able to breathe and go back to functioning health, not necessarily have a negative microbiological test. Obviously, they're very interplayed, and I'm simplifying the analysis, the relationship. But what I really want to encourage the TB think tank and everybody working in the field to start, we've got to start. It's no longer acceptable not to look only at microbiological cure. It's a very biological outcome. I mean, a very laboratory-based outcome. And actually, what people need to know is how are these regimens and how are these people leaving their lung function? What is it? Is regimen A better than regimen B? Is regimen B better than regimen A? Because if they're equivalent, but one causes much worse damage in terms of lung function, then they're not equivalent. They're only equivalent in terms of microbiological cure. And I think what you're seeing here is that the impact in terms of lungs, but not only in terms of lungs, but socioeconomic pathology is big, and it's been entirely underappreciated. Everybody has been very concentrated, and correctly so, in diagnosis and treatment of the incident TB, but we're forgetting the long-term impact. And for example, we've seen patients in our clinic even this morning who've got chronically destroyed lungs and will have to now live the rest of their life like that. And so this is really important work, and we are hopefully going to be able to present some new data and in the next couple of years, which will be awesome.
Thank you so much, Prof. We just have 2 minutes. We have a new question in our question box, and it's directed at Salome. They're asking whether the results in the functionality test for the spirometer and 6-minute walking test were corrected for patient characteristics such as BMI.
Yes, as far as I understand, the spirometry is usually corrected for other factors, not necessarily the 6-minute walking test, though.
I can jump in here.
Yeah, thanks, Brian.
Yeah, so by definition, you adjust on algorithms based on age, on gender, and on height, not BMI. So not weight. Weight is not included in your algorithm, but height is included in your algorithm. And that is what your adjustments is made for primarily.
Thank you, Prof. Charalambos and Alwood. in closing, I'd just like to thank everyone who attended this afternoon, and thanks for giving us your time. Thanks for the questions and thanks for the presenters. Join us again next month on the 17th of July as we have preliminary outputs from the TB investment case at the same time, 12 to 1 p.m. Thank you so much and enjoy the rest of your afternoon.
Thank you. Thank you,
Thank
everyone.
you.
Thank you.
Bye-bye.
Bye.
Bye.